So a 35-year-old woman walks into this high-end, completely sterile clinic for what is supposed to be a routine, like 15-minute cosmetic touch-up.
Right. Very standard.
Yeah, exactly. Soft ambient music is playing. She's, fully expecting to be back at her desk with a nice coffee in an hour.
Just a typical lunchtime procedure.
Exactly. But 4 minutes after the injection is finished, just 4 minutes, she is in cardiac arrest right there in the procedure room.
It's a terrifying scenario.
It really is. And you asked us to look into emerging aesthetic trends. And we found something in your stack of sources that is, honestly, it's going to completely change how you view these so-called lunchtime cosmetic procedures.
Oh, absolutely. It's a massive shift in perspective.
Yeah. So today we're pulling apart the medical journals and autopsy reports to figure out how a procedure marketed to you as minimally invasive can actually trigger this fatal biological cascade.
Because that term, minimally invasive, it really creates a false sense of security, doesn't it?
It totally does. So our mission today is to explore this rapidly growing field of non-surgical vaginal rejuvenation. And critically, we are zeroing in on the exact immediate clinical signs of what happens when dermal filler accidentally enters the anterior vaginal venous plexus.
Which is a highly specific and incredibly dangerous complication.
Right. Okay, let's unpack this, because the stakes hidden in these clinical guidelines, they're just incredibly high.
They are. And to truly grasp the precarious nature of what we're dealing with today, I want you to just kind of visualize a clinical anatomical map of the female pelvic region.
Okay, I'm picturing it.
Good. Because when people think of dermal fillers, they usually think of the face, right?
Right, like lips, cheeks, that sort of thing.
Exactly. And while the face has its own vascular risks, an experienced injector generally knows where the major vessels are. But the vulvovaginal area, specifically that anterior vaginal wall, is an entirely different landscape.
It's a lot more complex down there.
It's incredibly complex. It isn't just vascularized. It's surrounded by this wide, dense, and frankly, highly unpredictable venous plexus.
Which is basically a massive web of veins, right?
That's a great way to put it. It's essentially a thick web of veins.
Yes.
And navigating it blindly presents this potentially fatal set of risks that, honestly, many patients and even some practitioners are completely unaware of.
And yet, despite that vascular web, the demand for these procedures is absolutely booming right now.
Oh, it's skyrocketing.
Yeah, I was looking through the notes you pulled for this deep dive, and the sources highlight this massive rise in aesthetic gynecology. Clinics are heavily marketing treatments for vulvovaginal laxity, menopausal atrophy, and things like G-spot amplification.
Right. The market for this is expanding very rapidly.
But it isn't just about cosmetics, is it? Because I saw that Spanish prospective pilot study in the stack, and it was claiming some pretty massive functional improvements.
Yeah, they did.
So what exactly are they injecting down there? And, why are patients actively seeking this out?
Well, patients are actively looking to improve their quality of life and sexual function. And that Spanish study you mentioned, they actually measured this using something called the Female Sexual Function Index, or FSFI.
Okay, so there's an actual metric for this.
Yes, exactly. In that particular pilot study, the researchers injected cross-linked hyaluronic acid, which most people know as HA filler, directly into the anterior vaginal wall.
And the results were pretty significant, weren't they?
Very significant. The patients reported a mean improvement of over 68% in their sexual function scores at the 3-month mark.
Wow, 68%. That's huge.
It is. They also tested platelet-rich plasma, PRP, which showed positive improvements too, though slightly lower than the HA filler.
Okay, so the clinical rationale here, it's actually quite straightforward from a biomechanical perspective, right?
Mm-hmm.
Because the practitioner's basically aiming for the vesicovaginal septum,
Precisely.
which, just so we're clear, that's the tissue layer sitting right between the bladder and the vaginal wall, right?
That's the exact spot. By injecting a volumizing substance, whether that's HA, collagen, or even, a patient's own autologous fat, the goal is to temporarily increase the physical thickness of that urethrovaginal space.
So it's about adding bulk.
Yes. Anatomical studies suggest that adding volume and mechanical support to this really highly innervated tissue, it increases localized friction and sensitivity during intercourse.
Right.
But what's fascinating here is the stark contrast between the functional goal and the anatomical reality.
Because the goal is just simple structural enhancement.
Exactly. But the anatomic reality of that paravaginal venous plexus creates this high-stakes environment where, honestly, a millimeter of miscalculation or just a fraction too much pressure changes a routine enhancement into a literal fight for the patient's life.
Which, trying to visualize that tissue layer brings a very specific image to mind for me.
Oh, like what?
Well, it's like looking at a dense, highly pressurized wet sponge.
Okay, yeah.
And running all throughout the inside of this sponge is an incredibly complex, tangled network of these tiny, fragile tubes. Those would be the veins of the plexus.
That is a very accurate analogy.
So injecting filler into that space, it feels like trying to forcefully pump a thick, viscous gel into the middle of that sponge with the absolute requirement that you do not rupture a single one of those tiny tubes.
That's exactly the challenge. And if you push that thick gel into the sponge too fast, or, you've just used too much of it, the sheer hydrostatic pressure inside that confined space will force the gel to squeeze straight through the walls of those fragile tubes anyway.
Wait, even if the needle never actually pierced them directly?
Yes, even then. That fluid dynamic is the exact mechanism of failure in these catastrophic cases.
Wow, okay, that answers a massive question for me. Because, my initial assumption was that to get filler into the bloodstream, the injector would have to make a direct hit.
Like a vasocannulation.
Exactly. Where the needle goes straight into a vein, and they just push the plunger. But the literature explicitly notes that it's far more complicated and, frankly, far easier to trigger than just a simple needle strike.
Well, direct intravascular injection certainly happens. It's a real risk. But the pressure gradient you just visualized is equally dangerous.
Because there's nowhere for the pressure to go.
Right. The vaginal wall is a confined, relatively tight submucosal space. And practitioners are often injecting really large volumes to achieve that desired friction and thickening.
How large are we talking?
We are talking about up to 15 milliliters of hyaluronic acid in some cases.
Oh, wow. 15 milliliters is a lot of filler.
It's a massive amount for that area. When you rapidly introduce that much thick hydrogel into a tight tissue plane, the local pressure skyrockets.
And the body is also reacting, right?
Exactly. You combine that localized pressure with the natural involuntary contractions of the pelvic floor muscles around the vaginal wall, and you create this massive mechanical force.
It acts like a pump. Yes. That force physically drives droplets of the filler gel to migrate through the surrounding tissue and intravasate, essentially burst into the veins from the outside in.
It is terrifying to think about the body's own muscle contractions assisting in pushing that filler into the bloodstream.
It's a perfect storm.
Now, the sources make a very sharp distinction here between the risks of facial fillers and pelvic fillers, and it really comes down to arteries versus veins.
Crucial difference.
Because when a patient gets filler in their nose, the primary fear is hitting an artery. Arteries carry blood to the tissue, so blocking an artery cuts off the blood supply locally.
Which causes local necrosis.
Yeah, the skin dies. Or in some terrible cases, it causes blindness. But a vein in the pelvic region, that's the body's return highway.
Exactly.
If a thick blob of hyaluronic acid forces its way into that venous highway, it doesn't just stay in the pelvis, does it? Where exactly does a pelvic embolus go?
It goes straight to the heart.
Yeah. Veins exist to carry deoxygenated blood back to the center of the body. So, if a gel bolus breaches the paravaginal venous plexus, it instantly becomes a rogue projectile in the bloodstream.
Moving incredibly fast.
Very fast, it travels rapidly up the inferior vena cava, empties directly into the right atrium of the heart, passes through the right ventricle, and is immediately pumped out into the pulmonary arterial tree, which are the blood vessels that feed the lungs.
So it clogs the lungs.
It creates a physical barricade in the lungs known as a non-thrombotic pulmonary embolism, or NTPE.
Wow.
Yeah, if we connect this to the bigger picture, a localized elective aesthetic injection has just, with brutal speed, become a massive systemic cardiopulmonary crisis.
Which brings us to the absolute core focus of our deep dive today. What does this crisis actually look like in the room?
The clinical signs.
Exactly. If you are the practitioner holding the syringe or the patient lying on the table, what is the exact timeline and what are the immediate clinical signs that the venous plexus has just been breached?
It's vital to know these.
Looking at the autopsy reports and the ER case studies in your stack, The sheer speed is just breathtaking. We aren't talking about days here.
No, not at all.
Symptoms can manifest within a couple of hours. Sometimes it's 20 to 40 minutes. And like we said at the start, in the most extreme case documented here, the patient began to crash just 4 minutes after the procedure finished.
The clinical presentation is swift, it's violent, and it's driven entirely by the lungs suddenly failing to do their one job, oxygenating the blood.
Because they're clogged with gel.
Right. Because the pulmonary vessels are physically blocked by synthetic gel, the biological cascade triggers 3 distinct categories of red flags.
Okay, what's the first one?
The very first is profound respiratory distress. The patient's lung tissue is suddenly starving for oxygen. You will see them experience sudden dyspnea. They will start gasping for air, totally unable to catch their breath.
Like they're suffocating.
Exactly. They'll often begin coughing violently. And because the delicate microvessels in the lungs are suffering ischemic damage and basically pairing, the patient may exhibit hemoptysis.
Which is coughing up blood.
Yes, the terrifying reality of coughing up blood right there in the clinic chair.
And while the lungs are starving, the heart is suddenly fighting this completely losing battle, right? That's the second category, the cardiovascular collapse.
That's correct.
Because the pulmonary arteries are clogged with filler, the right side of the heart is suddenly trying to pump blood against what is essentially a concrete wall.
It's an immense strain.
The sources note patients reporting intense palpitations, extreme dizziness, and this very specific sharp chest pain called pleuritic pain.
Right, it hurts to breathe.
If you were to hook that patient up to a pulse oximeter in that exact moment, you'd see their oxygen saturation absolutely plummeting, throwing them into severe hypoxemia.
And that plummeting oxygen dictates the final, most severe category. Systemic shock.
This is where things shut down.
Completely. Without oxygenated blood circulating, the patient's skin, lips, and nail beds will rapidly turn a bluish hue, which is a clear sign of cyanosis.
The blueness.
Yeah. And the brain, which is incredibly sensitive to oxygen deprivation, it begins to shut down almost immediately. This leads to sudden loss of consciousness, or syncope.
They just pass out.
Exactly. And as the cerebral hypoxia deepens, the patient might actually begin convulsing, exhibiting seizure-like movements simply because the neurological tissue is suffocating.
Here's where it gets really interesting, though, and I mean that in a deeply tragic way. There's this massive diagnostic trap waiting for emergency responders, and the sources explicitly warn about it.
The misdiagnosis.
Yes. We have this detailed case study of a 38-year-old woman. She receives 15 milliliters of HA filler. She leaves the clinic, and within 40 minutes, she's experiencing those exact palpitations, dizziness, and she passes out twice.
Classic signs.
EMS arrives. They find her oxygen hovering around 80%, and they rush her to the ER. She is gasping for air. She's turning blue.
Yeah.
The ER doctors initially suspected anaphylactic shock.
They thought it was an allergy?
They thought she was having a severe allergic reaction to the filler.
Which, from a purely reactionary standpoint, is a highly logical deduction for an ER doc.
Is it?
Well, yeah. If you're presented with a rapidly crashing patient who just came from a cosmetic clinic where a foreign substance was injected, your mind naturally goes straight to an allergy. The rapid onset of respiratory distress, the cyanosis, the cardiovascular collapse, they mirror the textbook presentation of severe anaphylaxis perfectly.
Right. So they treated her for an allergy. They pumped her full of epinephrine. They gave her methylprednisolone, which is a heavy steroid, and this cocktail of antihistamines.
The standard protocol.
But her condition didn't improve even slightly. Her blood pressure kept falling, her right ventricle began failing from the strain of pumping against that blockage, and she eventually had to be placed on extracorporeal membrane oxygenation, or ECMO.
Just so a machine could bypass her failing lungs entirely.
Exactly. Why did the entire standard allergy protocol fail so completely in this case?
Because the underlying mechanism of the crisis was entirely misidentified.
It wasn't an allergy at all.
No. Anaphylaxis is a histaminic reaction. It's a chemical cascade triggered by the immune system that causes your airways to constrict and your blood vessels to dilate.
Right.
But what that 38-year-old patient was experiencing wasn't a chemical reaction. It was purely mechanical. The filler gel had formed an impenetrable physical barricade inside her pulmonary arteries.
Like a cork in a bottle.
Exactly. Epinephrine and antihistamines can change the dilation of a blood vessel, but they cannot dissolve a hydrogel plug.
Wow, yeah.
This profoundly highlights the critical need for both cosmetic practitioners and emergency room staff to instantly recognize these specific signs: the sudden breathlessness, the sharp chest pain, the cyanosis as a pulmonary embolism, not an allergy.
Because misdiagnosing a physical blockage as a chemical allergy delays the only interventions that might actually save the patient's life.
Precisely. You lose critical minutes.
And tragically for that 38-year-old, the delay and the sheer trauma to her body were just too much. She developed multiple organ failure and passed away 10 days after admission.
It's devastating.
When the autopsy was performed, they not only confirmed the massive HA embolism in her lungs, but they found that the sheer volume of filler injected into the vaginal wall had extended all the way to her rectal mucosa, with gross, visible embolization right there in the paravaginal vessels.
It's a really sobering reality, and it just underscores the violent fluid dynamics we discussed earlier.
Right, the pressure.
Yeah, and unfortunately, it's not an isolated incident. The sources detail another autopsy case involving the 35-year-old woman we mentioned at the start of our deep dive.
The one who crashed in 4 minutes.
Yes. She was injected with a collagen filler and a hybrid filler consisting of HA and polylactic acid, or PLA. Just 4 minutes after the procedure, her oxygen dropped, and she went into cardiac arrest.
And she didn't survive either, right?
No. She survived in the ICU for a month before finally succumbing to hypoxic brain damage. But her autopsy revealed something even more terrifying. The filler hadn't just stopped in her lungs.
Where else did it go?
They found filler particles lodged in the tissues of her heart and her brain.
Wait, let me pause you right there. If the venous system pumps the blood into the right side of the heart and then directly into the lungs act like a giant, dense filter of tiny capillaries.
They do.
So how did a thick gel manage to bypass the lungs entirely and end up causing a systemic embolism in her brain?
There are generally two physiological pathways for that kind of catastrophic bypass.
Okay.
The first is sheer, overwhelming pressure. If the volume of the filler bolus is large enough, the intense pressure from the right ventricle trying to clear the blockage can physically force microscopic particles of the gel straight through the pulmonary capillary bed and out into the arterial circulation.
It just pushes it right through the filter.
Yes.
Hmm.
The second pathway involves a structural anomaly called a patent foramen ovale, or a PFO.
What is that?
Roughly a quarter of the population has this tiny, often undiagnosed hole between the right and left atria of their heart. Usually it causes no issues at all.
Until there's a massive blockage.
Exactly. When massive pressure builds up on the right side of the heart due to a pulmonary embolism, that little flap can be forced open. This allows the gel embolus to bypass the lungs entirely, enter the left side of the heart, and shoot straight up the carotid arteries into the brain.
That is absolutely chilling. And it brings up a really crucial point about reversibility here. Because depending on what exactly is inside that syringe, the medical response changes drastically, right?
Oh, fundamentally.
We know that hyaluronic acid, HA, has a chemical reversal agent. It's an enzyme called hyaluronidase. We've seen it used to dissolve HA in the face if an artery gets occluded.
Right, it melts the filler.
But how do you use hyaluronidase when the HA is sitting inside the lungs of a patient who is actively coding?
It is an absolute logistical nightmare. I mean, while super-selective intra-arterial thrombolytic therapy has been documented, where interventional radiologists thread a catheter into the pulmonary arteries to deliver high-dose hyaluronidase directly to the clot.
That sounds incredibly slow.
Exactly. Attempting this highly complex, delicate procedure in the middle of a crashing patient scenario is just fraught with medical hurdles.
Right.
But as difficult as reversing HA in the lungs is, it remains theoretically possible.
Okay, so what's the alternative?
The far more alarming issue, and the one that cost that 35-year-old patient her life, is the use of semi-permanent or permanent particulate fillers.
Right, because her injector used collagen and PLA.
Huh.
And the sources list other popular particulate fillers too, like calcium hydroxyapatite, polyacrylamide hydrogel, and even liquid silicone.
Yeah, for those particulate materials, there is no hyaluronidase. There is no chemical reversal agent on the planet.
Nothing dissolves it.
Nothing. If a permanent filler embolizes into the venous plexus and travels to the lungs or the brain, there is absolutely no chemical mitigation that can dissolve it. The physical blockage is entirely permanent.
So what can doctors even do?
The clinical focus shifts immediately and exclusively to extreme supportive care, like ECMO or mechanical ventilation, which, as the forensic case studies brutally demonstrate, is often nowhere near enough to overcome the physical destruction of the tissue.
Wow. If the cure is that complex, or in the case of particulate fillers, literally non-existent, then prevention has to be the only actual cure here.
It really does.
What protocols exist to stop this from happening in the first place? Because again, we are talking about elective procedures happening in outpatient lunchtime clinics.
Well, the clinical guidelines from the American Board of Cosmetic Gynecology, alongside various aesthetic safety panels, they do lay out very stringent, procedure-specific safety protocols that absolutely must be followed.
What's step one?
First and foremost, the use of blunt-tipped microcannulas is highly recommended over sharp hypodermic needles.
Because they're less likely to pierce a vein.
Exactly. A blunt cannula is designed to push vessels aside rather than slice cleanly through a vessel wall.
That makes sense.
Second, the physical technique matters immensely. Injectors must use slow, deliberate injection speeds with very small incremental volumes.
To avoid that pressure spike.
Exactly, to prevent the creation of that massive local pressure gradient that forces the gel into the veins.
And the sources emphasize aspiration too, right? The injector is supposed to pull back on the plunger of the syringe for a few seconds before actually injecting the gel.
Yes.
If they see a flash of blood enter the syringe, it proves the tip is sitting inside a blood vessel, and they know to immediately pull out.
Sustained, gentle aspiration is mandatory, but even a negative aspiration is not completely foolproof.
Really?
No, especially in an area as dense and highly pressurized as the vaginal wall. This raises an important question about where the standard of care is ultimately heading.
What do you mean?
Given the severe anatomic variations from patient to patient in the pelvic venous plexus, there is a rapidly growing consensus in the medical literature that ultrasound-guided injections must become the absolute norm.
Oh, so they can actually see the veins.
Exactly. Using a high-frequency ultrasound device to physically map out the patient's unique aberrant vascular structures before the needle ever touches the skin, and perhaps even guiding the cannula in real time on a monitor. It is one of the only definitive ways to navigate around these vascular landmines.
Wow. So what does this all mean for you listening right now? We've covered some incredibly heavy, sobering physiology today.
We certainly have.
Let's synthesize the crucial takeaways here. We know that cosmetic gynecology treatments aimed at vaginal laxity or sexual function offers benefits that can genuinely improve a patient's quality of life. The data absolutely supports that.
It does.
But the unchangeable anatomical reality is that the anterior vaginal wall is a highly unpredictable vascular minefield. Whether you are a medical practitioner performing these aesthetic procedures or a patient considering booking one, the most critical takeaway is recognizing the immediate clinical signs of an intravascular venous injection.
You have to know the red flags.
If, within minutes or hours of a vaginal filler procedure, you or your patient experience sudden breathlessness, coughing up blood, profound chest pain, a bluish tint to the skin, or a sudden loss of consciousness, it must be instantly recognized as a cardiopulmonary crisis.
It is a pulmonary embolism.
Yes, it is not an allergic reaction. Misdiagnosing it as anaphylaxis only wastes the very few minutes you have to save a life. It fundamentally reshapes how we need to view these treatments.
Duh.
Minimally invasive does not mean zero risk.
Not at all.
It just means the incisions are small. The biological states inside the body can still be as high as any major open surgery.
And that leaves you with one final, perhaps unsettling thread to pull on your own.
Okay.
We've focused heavily today on the immediate physical dangers of these fillers entering the bloodstream. But if we pull back and consider the long-term regulatory and socioeconomic ripple effects, a new picture emerges. If a synthetic substance, injected purely for elective aesthetics, can migrate, permanently lodge in the body's vital organs, and carry an instantaneous risk of death, how long will it be until life insurance companies or health insurers begin requiring full mandatory disclosure of all lunchtime cosmetic histories before issuing a policy?
Oh, wow. I hadn't thought of that.
If permanent hydrogels are sitting in our tissues, blurring the line between routine cosmetic care and high-risk medical implants, at what point will the entire healthcare system be forced to radically rewrite how it underwrites the cost of human vanity?
That is heavy. It definitely makes you look at that plush, sterile clinic waiting room and that iced coffee a whole lot differently, doesn't it? Thank you for letting us guide you through this deep dive. Until next time.